So a warm welcome to all the delegates. This is the first joint webinar by ISAM-NExT and WPA-ECP section. And the joint webinar is on the difficult clinical cases in addiction psychiatry. So there has been a huge response. We have got around 113 registrations from nearly 30 countries from all the 6 continents, so except Antarctica. So coming to some housekeeping rules, the webinar is being video recorded. So I am requesting everyone except the speakers to please remain muted during the talks. And in case you want to ask any questions or give any comments, please use the chat box for the same and raise your hand for the question answer session during the question answer session after each talk. So the agenda for today's meeting is, so I'm reciting the welcome message and the agenda. Then the introduction of the chairpersons will be done by the moderators, and the chairpersons will then be delivering their messages. Then the introduction of the speakers will be done by the moderators. And then the case presentations by the speakers will be done. And question answers will be taken up after each case presentation. And then the webinar will be concluded. So for today's webinar, the chairpersons are Professor Alexander Baldacchino, President ISAM, and Professor Afzal Javed, President WPA, and the speakers are Dr. Angeline Hanapi from ISAM-NExT and Dr. Sachin Nagendrappa from WPA-ECP. So now I'm handing over to Dr. Rose.
Thank you, Preeti. Preeti is our member secretary of ISAM-NExT. As a chairperson of ISAM-NExT, I'm very excited about this webinar, and I'm very happy about the response we got. It is my honor and privilege to welcome Professor Afzal Javed, who is the president of WPA, that is the World Psychiatric Association. All of us know him. He is a renowned consultant psychiatrist from Pakistan, working in UK, specialized in social and transcultural psychiatry, psychosomatic medicine, and schizophrenia. He has served on various boards and organizations, including World Association for Psychosocial Rehabilitation and the Royal College of Psychiatrists. And he has published more than 150 scientific papers and monographs. He has received a recipient of various awards, and one of the major award is he has received highest civilian award of Pakistan last year. And he is an eminent teacher at Warwick University. Sir is an associate professor, and he is a great teacher. So we are fortunate to have him as a chairperson for this webinar. We welcome you, Professor Afzal Javed from ISAM-NExT.
Well, good afternoon, good evening, dear membership of ISAM, WPA, ECP, and our young leaders. Let me first thank all of you for taking this initiative. And we must appreciate and acknowledge the efforts done by the leadership of ISAM, which is going to be an important collaboration with WPA. All of you will be pleased to know that recently WPA and ISAM signed a memorandum emphasizing the need of sharing and doing some collaborative work between these two organizations. And I must say that our younger colleagues I always call them young leadership of WPA, they have been instrumental in getting ISAM on board for this particular webinar. I don't want to emphasize more than this that addiction medicine, problems with drugs of abuse are integral component of mental health problems. And whenever we talk about mental health, we always say mental health and drug abuse problems. And general psychiatrists who are not expert, who don't have expertise in addiction medicine, they always look to the addiction specialist for getting guidance and advice about the recent advances. I'm sure ISAM's support and our ECP's initiatives and leadership, these joint seminars will become a norm rather than an exception. And we hope that this particular collaboration will develop into having webinars in some other languages so that people speaking non-English languages equally benefit from this expertise. So I, on behalf of myself, on behalf of the Executive Committee of WPA, I'm really thankful to Alex, the President of ISAM, and his committee for doing this wonderful initiative. And of course, last but not the least, the leadership of our section on early career psychiatrists are definitely a blessing and asset for WPA. I look forward listening to the webinar, and I hope that this is a beginning, not the end. Thank you very much, Alex. Thank you very much, our younger leaders, and thank you very much, ISAM and ECP.
Thank you, Professor Javed. I would like to now invite Dr. Mariana Pinto do Costa. She is my colleague, and she is a chairperson of WPA ECP section.
Thank you so much, Professor Afzal Javed, for the words and for the support to this initiative. And thank you so much, Roshan, for the kind introduction. And it has been a pleasure to be discussing this initiative over the summertime, and now to have finally this webinar in place. As Roshan was mentioning, I'm the chair of the Early Career Psychiatry section of the World Psychiatric Association. And we have as members either psychiatric trainees, so people that are doing their training in psychiatry in different countries, or people that have finished their training in psychiatry in the last 7 years. Membership is free. We have a page in the section Early Career Psychiatrists in the World Psychiatric Association website, so you can go there and you can see how you can join the section by sending like your CV and a motivation letter. So we're very much looking forward to have as much as all of you in our section. Today, it is my great pleasure to introduce Professor Alexander Baldacchino, who has been instrumental as well to have this webinar today. He's a professor of medicine, psychiatry, and addictions at the University of St. Andrews, and he's a consultant psychiatrist at the NHS Addiction Services in Scotland. He's the president of ISAM, and he's the principal investigator in the UK to a number of European Union funded projects, some of which included barriers and challenges faced by individuals with substance misuse, a cross-cultural multi-center study to determine the nature, extent, and management of drug-related mental health problems, but also as well internet and drug addiction. And he has published extensively in different journals. So thank you so much, Professor Alexander Baldacchino, for your support and for being with us today. I look forward to hearing from you.
Thank you very much, Mariana. It's a pleasure to be here, and an even greater pleasure to be here with WPA colleagues. And I'm saying this because this is, in a way, a very real, not just a symbolic moment where the two international organizations are working together. We've been talking about this for a number of years, but hey ho, you know, the ISAM-NExT and the early professionals career section has, you know, taught us a lesson here of, you know, less talk and more action. And but, you know, in a way, I think we want to remind ourselves, most of us who are organizing these webinars, and hopefully there'll be more webinars like this, are clinicians. We have a duty of care. We want to give the best to our patients. And also we are part of a system. And that system, as you know, tend to falter when we tend to work in silos or in isolation. And this is a very good example of how, you know, people can talk about dual diagnosis, can talk about comorbid mental health and substance misuse. And I'm very encouraged by Professor Javed, who clearly said this is mental health and substance misuse, drug use. And because we work in a cross-sectional way in the field of addiction psychiatry, in the field of all component sections of psychiatry. We cannot work in isolation. And as a result, our knowledge acquisition and our aspiration to our patients, not just to ourselves and to the team, it needs to be intersectional, interagency, multidisciplinary, and all of the above. And that reflects itself in the way the WPA and the International Society of Addiction works. We try to encourage people to think about addiction as something which is of core business, core values, because at the end of the day, we cannot separate one or two problems that the patient appearing in your clinic and ignore the rest. And so I think, the future is bright. Thank you very much, Mariana, and thank you everyone who's organized this webinar. One of many, I know, not rather than I hope.
Thank you, Professor Bandajino. Now moving to case presentation, I would like to introduce now Dr. Angeline Hanafi. She is a ISAM-NExT member from Indonesia, Jakarta, Indonesia. She's an early career psychiatrist working and has an interest in addiction psychiatry, mainly in behavioral addiction and also psychiatric conditions and HIV comorbidity. She's also part of the training subcommittee of ISAM-NExT and active member of ISAM-NExT. So I would like to invite now Dr. Angeline Hanafi to introduce herself and go for the presentation.
Thank you for the kind introduction there. Good afternoon there. It's quite an evening for me. It's almost 9 p.m. in Indonesia. So very nice to have this opportunity to share with you some cases that we faced in Indonesia right now. Maybe it's not like what you imagine. And today I would like to share, let me share the slide right now. Okay. Before I start, I would like to thank WPA and ISAM-NExT, of course, for the opportunity sharing these cases today. Today is not me only sharing cases, but we will have discussion because in these two cases, we have quite a difficulty in maintaining the therapy as well as continuing increasing their motivation to have therapy with us. So the slides today I made together with our team back there in Jakarta, Indonesia. We have a special clinic for addiction together with my mentor, Dr. Christiana Sister. She's also here today. And the two cases that we will share today are about gambling disorder. So I will give you a little bit of a background first, why we discuss behavioral addiction, because it is a new trend and there's no guideline in the world as well as in Indonesia. And we did some survey back then during 2020 and 2021, and we found out that internet addiction, the prevalence of it is about 14%. And what is very interesting here is the people coming to our clinic in the early pandemic is not, I think it's not like most of them are not substance use disorder patient, but most of them are parents with their children having this gaming disorder cases. And now on after we are in the third year of pandemic, or maybe the end of the pandemic, hopefully, we have increasing cases of gambling disorder. although maybe you should have known that in Indonesia, gambling is strictly forbidden. It is criminal offense in Indonesia. So if you found out by the government that you're gambling something, then they will charge you with criminal offense. Then of course, some of the effort have been done by the Indonesian government. They blocks all gambling sites, but it is still easily accessed by everyone in Indonesia via VPN. And when we did a little survey back then in 2021, and we found out the prevalence of gambling disorder is about 1%. In the population, nearly 220 million people in Indonesia. And we have several challenges that is very specific to our countries. The first one is the presence of online loan services. Later on, we will discuss about it. And the second one is the pandemic itself. So what we thought were happening back there is during the early pandemic, people who never gamble really like feeling bored and they try to gamble online and they're like just trapped in the cycle of gambling disorder. So that's a little bit of a background of gambling in Indonesia. I will present two cases. The first case is a case of a patient with very low motivation to change. We have a very challenging therapy to do. It is not finished until now. So we'll tell you why it's still very difficult for us to do the therapy with this patient. So this patient is a male, 31 years old. He was married with 2 children. He was the first son of the family, and especially he was a medical doctor, and he was currently a medical specialist resident or registrar in our campus. And he came to our clinic because of the referral from the father. I will explain a little bit about the family later on. So we'll touch a bit of description about the gambling type. This patient has gambled soccer for most of his life. He loves soccer since he was very young. Through gambling, he experienced more intense excitement than just watching the game. So he tried this online soccer gambling on either smartphone or laptop. It's including 3-way money line, correct score, or goal scorer. So he never really take a bet on something very general, but it's more specific. Who will score most, then who will bid to score, something like that. Then he said he had lost more than he gained. He started to take numerous legal and illegal online loans. As you can see, this is the example of the websites that he was using. You can see on the left-hand side, it's one of the websites. And as we found out these last 2 years, it is like the website that everyone is using if our patient is coming for soccer or other sports, esports, gambling disorder. Then you can see on the right-hand side, I have screenshot several things. The first one, the small one, are several logos. Those are all the online loan services, maybe the legal one and also illegal one. So the illegal one you can have when they, like this person or maybe like an organization will kind of spam you with like offered for you to take loan from them. Then they will charge you with very high interest, and then you will be trapped by it. The problem is if you don't pay these illegal loan services, then they will kind of terrorize you and your family, and somehow they will have all the contacts in your contact books. And that's the real problem that the patient and family are having. Usually it's not very hard to take loan from these services. What you have to do is just your identification card and your bank number. Then we ask the patient whether he has several triggers for him to have this craving of gambling. He said that the first one is messages from debt collectors, something like the one that I showed you before. Then the second one, it's quite interesting, is that like some of Indonesian soccer team, they have like sponsored by some legal loan services. So they will put their logos on the jersey, the team jersey, and the patient said that by seeing the logos of those loan services on the player's jersey, then they will he will felt like the craving will increase a lot. Then watching a soccer match, of course, because he always took a bet while watching a soccer match. Then looking at a live match scores, this was what he did if he had like so many loan, the parents know about it, then he couldn't access the websites for quite a long time, but he will like insist on looking on this live match scores. The other one is are several triggers, internal triggers that he was feeling, for example, feeling bored and stressed out from academic issues. If you can see what we wrote here today, the vicious cycle has occurred for more than 8 times. So he will like come contact with the triggers, then he will gamble, then he will accrue debts, and it will be paid by the family in full amount. Then he always came to the clinic but did not feel losing money is such a big deal because his father always saved the patient to maintain a family image. He has this denial because the community still respected him as good medical doctor. As I've said before, he was resident, and he was actually a chief resident. So in Indonesia, if you are a chief resident, it means that you're really superb in all your academic and non-academic like results. But of course, this gambling disorder has caused him not to being able to focus 100% on those tasks, but he will like kind of lie to everyone about this. Even if the debt collector contacted his friend, then he will say that like someone hacked his phone or something like that. Then the second problem that we are facing is about his father. His father is a professor in our faculty, so a very powerful one. And the father always paid on all his debts because they really think that it was a bad thing or a taboo for everyone to know that his son is having such a problem. So it will create a vicious cycle that the son thinks that it's not his money he's losing, and the father could not just live with all those debts. So because it happened quite like a lot during these 2 years, I guess in the last years, he was relapsing for about 5 times. Then his father started to show symptoms of depression because of the patient's attitude and repetitive cycle, and the whole family began to have financial problem. Of course, you will ask what happened to his wife. His wife was also estranged from his larger family because they kept on pestering her about this problem. But the patient and family refuses to face the problem and choose to sweep the matter under carpet. So who knows about this problem is us, the therapists, and also the family. We did some measurement using instruments. So you can see that we are using 3 instruments here. So we are kind of in this supervised by staffs from Flinders University, and we are told to measure things. Then something that we measured is about the whether he thought that the gambling disorder was causing harm to him or his family. So actually, he felt quite enjoyment doing gambling, and he also identified that he was causing harm to himself and also his family or his partner. Then when we see the cognitive error of this patient, about 80% of what he was thinking about is inability to stop gambling. He really believed that he will not be able to stop his online gambling habit. Then he has this interpretive bias and quite a large cognitive thought of predictive control problem. Then the urge during the visit day is about 18, and the past week is about 25. This was out of 40, if I'm not mistaken. So we were giving him acetalopram, 1 tablet a day during the time, and he consumed it irregularly. Why we gave him this medication? Because every time he came, it means that he has made quite adept. Like he would feel like such a failure. He would like to kill himself. He has the suicidal ideation, self-harm ideation. And it is until the point of we thought that better if we admitted him in the hospital. But back again, he was a student in our hospital and in our faculty. So it's quite difficult to do that without everyone know about his condition. So we did CBT as well. It's scheduled fortnightly, but he came only once every 2 months and only when a new debt was known by his father. So his father always forced him to come as condition for debt repayment. But it always like that. So after several meetings, then he will kind of just lost of follow-up. So he will not come after like 2 or 3 meetings. So what we learn here is the challenges. The first one is the profession. As medical doctor, he is currently in specialist training. So if gambling issue exposed, it could mean expulsion from the faculty. And the family also, because he came from a very well-known family in the university, they were not ready to give him any consequences. And we know that in Indonesia, gambling is a big taboo and no one should know, especially family with very high educated members. Then, so we are unable to implement money management in strict behavior, and patient and family, maybe more towards his wife, because his father know that the therapy is actually good for him, but they could not really force him to go to the therapy if he won't do that. So that's challenges in the first case. maybe later on in the discussion, we would like to know what's your view regarding this first case, because we're still facing this particular problem in our clinic. Then we have the second case. This one, we identified the problem quite interestingly back then, and we found out like a way to deal with this. This is a case of unique gambling type. It's gamified gambling. So he was a male, 32 years old, married with one child. He was the youngest of 4 siblings, so he was the only male in the family, because the father already passed away as well. His occupation is CEO in family businesses, and this created quite a problem because he took all the money from family businesses to the gambling. He was an IT graduate. So he used to play online games back then before pandemic, but after the pandemic, he attracted the probability elements of those kind of online games, for example, the gacha system in the games. Then one day he was introduced to online slots by a friend, and he felt it was very interesting because it was kind of similar to his games or his kind of hobbies to do that. He preferred cute designs, for example, candies or animes, and he enjoyed it because the money there, he felt it's not real money. So what I would like to say, this is not diamond, this is a real currency. So later I will show you that it's the money there is in rupiah. It's the currency in Indonesia. Then he tend to change from one game to the other due to belief of unluckiness. If he played this one type of game, then he lost quite a bit during the day. Then he'll change to the other game with the same like style of the game. So he always used his own or family's money, but never online loan services. He spent at least 1K per day and can purchase about 10Ks a day for free spin. What he explained it as free spin. He acquired about $5 million debt, and he would embezzle his sister company funds. So what we say just now, that he was a CEO in a family company, is actually a company owned by his sister. So he just took off all those money to do this, like a very interesting kind of gambling habit. He stopped gambling in November last year to do that, and his family know about his condition. He would explain this experience of physical withdrawal, sweating or increased heart rate, and anxious and dysphoric condition when he was having this craving condition. This was the real examples of the games he was playing. This on the left-hand side is the websites. Then this was how he plays. I will show you. Okay, as you can see here, the games looks like Candy Crush. Maybe you know Candy Crush. Then you should like just play this game. Then if you could not win about like 8 spins or something, then you can buy free spins from them so that you can shuffle the game. Then you can see on the down here are where's the amount of money you are having as a debt. So for example, you are having 2 million of credits, then you bet about 2,000 rupiah. Then what has happening is you are able to complete the level, then you will have that money. Okay. So he also has previous addiction history. So he used cannabis and he went to rehabilitation in 2014. He also drank alcohol about 1 to 2 times a month until passed out. And he smoked a pack of cigarettes per day. So his father was also a substance use disorder patient. His elder sister has a bipolar disorder. And throughout the father's life, his father was very aggressive. So he has very poor relationship with all children. And the mother was the breadwinner and busy taking care of the father since the patient was very small. The second sister was the one having the company that he embezzled the money from. So the second sister refused to interact with him due to this embezzlement problem. If we see the whole family, he had an accident with his wife 3 years ago and decided to get married, and he's currently living with a child, and he got into fight with his wife since the gambling problem exposed. He was also having financial difficulty of not becoming the CEO anymore, since he has to support the family. These are the measurement using the instruments. As you can see, he felt a very high enjoyment in doing the activity that we were showing you. The gambling in his life took about more than 50% in 24 hours, and he has very high illusion of control, inability to stop gambling, and still a very high urge. He was admitted to our hospital about, I think, half a year ago. And at the time, he tried to kill himself and he could not control his gaming and gambling problem. We gave him antidepressant. And at the time, we asked him to do money management with the family and also graded exposure therapy. So as usual, we identified his triggers, for example, feeling bored, thinking about his debt, conflict with his wife, because the wife was having this histrionic trait and always asked for persistent attention from him, and he felt quite stressed from that. Then if he was feeling guilty, seeing similar gambling games design, hearing sounds similar to one during gambling or playing games. So it creates a cycle of situation, then we'll have arousal during the craving, then it will lead to some thought about doing gambling, and the behavior usually was gamble away all his money. So we decided to do a graded exposure. Beforehand, we asked him to rate which one is affecting him less. Then he said front page of the website is something like this. Then the second one was the page of choosing games. Looks something like this. Then the page for pragmatic slot game choices is this one. And usually he chooses this little one, Sweet Bonanza. It looks like this. So we did graded exposure using images first, as you can see back there when I clicked just now. So we start with the number 1, then go through number 4. We use this therapy worksheet. We started from the first target number, then goes to the highest one when he felt like he could control his urge during the time. After images, then we go to the video. I will not show you the video, but we kind of making a video for his step on like doing the gambling, then do this all over again. So I think that's all for our case presentation. Maybe we can discuss lots about it. I could not do this without our team in our addiction clinic. Then we are also in collaboration with Flinders University and statewide gambling therapy services led by Professor Michael Bagent. Thank you so much. I will start sharing and we'll start the discussion.
Thank you, Angeline, for presenting two interesting cases for our audience. With the permission from our chair, Professor Afzal Javed, I would like to now open a floor for a question and answer. So we have 10 minutes for question and answers. So if you have any question and answers, you can raise your hand and ask the question. And before that, we also have one question in a chat box by Dr. Bigya from Nepal. So she has actually asked 3 questions. So first question is whether there was a psychiatric comorbidity in a patient like disorders, depressive disorder or social anxiety disorder or personality disorder in the first case. And second question is about the express emotion. So whether there was a component of express emotion and how it was addressed during the therapy. Yeah.
Okay, thank you for the question by Dr. Bigya. If I'm not mistaken, I'm very sorry if I misspelled your name. Okay, so the first question is about comorbidity of the first case patient. When we try to assess him, he has this personality disorder. If we're kind of making the diagnosis, he has this narcissistic personality disorders that he always in denial with what he was experiencing right now and doesn't really think that his family would like to help him about this condition. And the wife also was very permissive of him. He kind of always threatened the wife to give him money. So the wife, very permissive. That's why the wife was hated by the family, because the wife always giving him the access to all his gadgets, to all his like the accounts. So it's quite difficult to involve the wife during the cycle because the wife felt that she could not do anything about his husband's gambling habits. And we tried to move him from his home back to his parents' home. But the problem is he was experiencing like a very high pressure from the family. The father is a professor in that particular field he was studying on right now. So he always felt that the father always tried to ask him about his academic his thesis or how he was doing on with his residency, something like that. So the communication was very off in the family. The mother doesn't really know what to do except paying all his debts. So sometimes this depression will occur, but it will only like persist until all his debt was paid off by the father. Then he will feel okay after that.
There's another question by Dr. Bigya from Nepal regarding the privacy of and how the privacy can be ensured because the patient is a physician and working in the hospital, and if privacy is not ensured, that can barrier for treatment. So how it was ensured?
Okay, thank you for the third question. This privacy is quite a problem. So we did like 2 ways in regards with this. We're also very concerned about this privacy. So at the time, at the beginning of this like meeting, we asked him to go to our department to have the session there. But we have this we discussed with several of our colleagues that it will not be therapeutic at all to do it in our department. So we moved him to our clinic. And when it happened in our clinic, it always like maybe not in our service time. So it's very late in the evening. So no one will know about he coming to our psychiatric unit, something like that. So other than that, we did not really like type anything to his electronic medical records, because the system in our hospital was that everyone can see the medical records. So even if you are not the doctor responsible for this patient, but you can still see the medical records. But so that's one of the 2 things that we did. So we make a separate notes about his condition and just put in the manual medical record.
Okay, thank you. I can see Professor Baldacchino, sir, want to ask something? Or sir, your extra
Yes.
comments.
Yes, Angeline, thank you very much for those 2 case presentations. And it sounds like, you know, trying to internally motivate the 2 patients that you have can be very difficult, especially when you have, you know, the wrong social setting, the wrong negative expression, you know, expressed emotion, but also, you know, the inability to be able to do things in a certain confident way, because either, you know, the person is going to be known or identified, etc. I'm just thinking here, Angelina, I didn't hear from your presentation. When you have cases like this, do you have a program where you think about risk reduction rather than treatment, and hoping that the antidepressant and the associated psychosocial support would work when it doesn't work because of lack of insight or lack of remorse, etc.? You would think, like we would think about people who are injecting heroin, etc., to do a program of harm reduction.
Okay, thank you, Professor, for the questions. So the problem we are having is because this one is online gambling. So we try to make a risk reduction with this patient by limiting his gadget like accessibility. So for example, from smartphone, we downgrade to like a very small RAM smartphone that he could use during his residency period. Then we also ask him not to be alone while using like several of his gadgets. Other than that is money management. So we ask the father to take all of his accounts and try to change the PIN number or the credit. We take all his credit card and identification card, because the identification card he can use for legal and illegal loan services. So something like that. What we are trying to do is just that, while still trying to protect his privacy at the moment. Maybe you could, you have like several suggestions about this.
Not really, because you know the patient very well. I'm just wondering if this person was not a doctor or a CEO, was you know, a person who's not, you know, achiever, etc. Would the therapy be different? There seems to be, you know, a lot of the complexity of the cases seem to be because of the way the person sees himself or herself high achieving, very successful people, and the as you're saying, there's an element of narcissistic, component here. But if this person was not a CEO, do you think it would be less complex, and you're more able to introduce harm reduction measures?
Okay. I'm sorry, Professor. The first case is a medical resident, and the second case is the CEO. So after this problem was known by his family, he was taken down from CEO position. So he just did not work at all. He spent all of his time at home. So they stripped all of his ability at the moment. And he still have this feeling of boredom and maybe don't really know what he would like to do next. Then this was the problem that he was facing right now. So we're trying to change the whole situation. But when the whole situation was changed, he still have this huge craving of doing this gamified gambling.
Thank you.
Thank you, Professor Balachandran, for your questions and insight, and also Angeline for presenting cases on the time. Because of paucity of time now, we will take other questions. You can actually respond in the chat box, Angeline. There are a couple of more questions also. And meanwhile, I will hand over floor to Dr. Mariana to invite a second case presentation.
Thank you so much, Roshan, for the introduction. And thank you so much, Angeline, for presenting like two very interesting cases. I think it has been evident that there were a lot of questions, and sadly we can't cover them all. But if you can so kindly respond to what has been raised over the chat, I think that will be very, very interesting. So it is my great pleasure to introduce the next speaker, who is Dr. Sachin Nagendrapa. He's a member of the Early Career Psychiatry section of the World Psychiatric Association, and he has a special interest in addiction psychiatry. He's currently working as an assistant professor at the St. John's Medical College Hospital in India, and he's also the assistant editor of the Journal of Psychiatry Spectrum. He has been awarded a number of international recognitions, and he's very passionate about research and currently involved in a number of international collaborative studies. So thank you so much, Sachin, for agreeing to present today. And if you can share your screen, we look very much forward to hear your clinical case.
Yes.
Thank you so much.
Thank you so much. Can you all see my screen?
Yes, we can.
Yes.
Yes. Thank you, Mariana, for the kind introduction. And I would like to thank ISAM and WPA for giving me the opportunity to present. So today I'm going to present a case of cannabis dependence syndrome in background of intellectual disability and externalizing temperament. So, and my disclaimer is informed consent has been obtained from the patient, and also there are no conflicts of interest. So learning objectives of this case as what is the vulnerability and susceptibility for the dependence, and before, beyond, and after substance dependence use, and also substance use with comorbid intellectual deficits, and what are the difficulties in treatment, and also while there is a externalizing temperament, what are the vulnerabilities, all those things we are going to discuss. So this is just an slide about the prevalence of cannabis use in India. So in India, India is a vast country with like huge population, and it stands second in the world, and it's going to soon to be the first, beating China. And we most of the cannabis dependence, even though the prevalence are very common in all the states, especially the northern part of India has the more prevalence, especially in males. So, and also this slide also depicts what are the top 5 states, and mostly in the northern part of India. Okay. Yes. So what are the factors usually which causes the influencing the use of the substances? So usually age usually begins in the teenagers and maximum use in early 20s and gradually declines in late 20s and early 30s. Among the adolescents who try cannabis, about 1/3 will use it regularly. And of these, most of them stop by the age of 30. And most common, can you hear me? There is any problem?
We can
No.
hear you
Okay,
well.
okay, sorry. Yeah, sorry. And about 10% of the people who use cannabis in the early ages, they usually develop long-term dependence to the cannabis. And coming to the case presentation, overall, I'm going to take a different case as compared to the earlier presenter. What I'm going to do is because this person has the intellectual deficits and vulnerability from the birth aspect. So I'm going to start from the beginning. Here is Mr. S. He's a 21-year-old single gentleman. He is a 11th grade dropout, belongs to the lower socioeconomic status, and he is from the urban Bangalore. It's part of southern India. And informant was his mother, and most of the information given by his mother was relevant and adequate. And he presents with the complaints of poor academic performance, hyperactivity and inattention, stealing behavior, aggression when demands are not met, use of cannabis for the past 3 years, and nicotine use for the last 3 years. And one of the commonest complaint we do here is regarding the academic performance, especially when the parents bring the children or adolescents, they are more concerned about their academic performance rather than even though there are many other major symptoms. So this was a major complaint from the mother. And so let's begin from the birth history. Even when his mother was pregnant, so there was no antenatal concerns during the pregnancy except hyperemesis gravidarum, where mother had excessive vomiting and she took treatment for it. Apart from that, there was no other infections, and she has taken all the vaccinations as per needed, and also she was regularly visiting obstetrician for the antenatal checkups. So that was the thing. And during delivery, there was an issue where the obstetrician felt there was a polyhydramnios, and there was difficulty in labor. That's why they have taken for the cesarean section delivery. And soon after the delivery, the baby didn't cry immediately after birth, and required for the neonatal intensive care admission for 1 week. So, and developmental history, once the baby got discharged and family mother has noticed, and the patient has 2 siblings. So mother exactly can't recall the specific milestones, but clearly she can tell that there was a delay in milestones, including the motor, where he was not walking or holding the neck or starting like monosyllable or bisyllable words, or including social smile. Compared to 2 of his sibling, it was late in all kinds of milestones. And there was also excess drooling of saliva when he was child. It may be due to a delay in development of muscles, and also lack of swallowing of saliva, all those. And also there was undescended testis, and he underwent surgery at the age of 6 years. And also mother noticed child was not active. Active in the sense, like mother was mentioning, child was not socializing with other children or with the family. And also academically, when family started teaching, he was not so keen on learning, just like other children's of his age. Mother used to assist him in most of the daily activities, including bathing and brushing, which was not seen in the previous 2 kids, according to the mother. But it was also difficult to make him sit at one place as child was moving restlessly. So mother also always complained that he had a lot of injuries because he was always running around the house, and it was difficult to make him sit at one place. And schooling. When he was joined school, even though they tried to join him for the preschool, he couldn't join because he always used to come back to the home. And when he joined the school at the age of 5 years, teachers also they frequently complained mother that her child is inattentive in the class and can't sit at one place for a long time. And also he was not able to play with the other children, as he was not able to wait for his turns to come. So he was so impulsive during that time. And there were complaints from the other family members or other parents that he used to frequently hit the other children also. And again, the poor academic performance continued, and he was not able to read and write even during his third, fourth grades. And even after teachers took extra efforts, it was difficult to make him understand. And also he was sent to multiple tuitions, but he couldn't do well in the academics. Mother also noticed social interactions were poor, and mother reports that he doesn't know how to interact with the others. And teachers used to pass him in exams and make him move to higher section based on the parents' request. So parents used to go and request, and even though he performed poorly, they used to request and move to the next grades. So overall, the poor academic performance continued both in primary and high school. And there was difficulty in getting, like if he goes to buy some groceries, and there was difficulty in getting changes from the shop, and also including if somebody asked the time, he had difficulty in telling the time. And he uses, his family run a grocery shop where he uses for simple calculations also. Even during his high school, he used to use calculators. And after his father's death also, there was no emotional response from his side. And despite the financial crisis, doesn't stop him in demanding the huge money. He used to demand the money. Later I'm going to tell like why he used to demand money. And his demands, whenever he demands, it has to be met immediately. Otherwise, there were behaviors like throwing utensils from home or breaking the glasses or breaking TV. So he has made a lot of damage. And also there were some behaviors like used to shout and physically abuse his mother also. And there was also stealing behavior noted during this time in the early childhood, where if the demands are not met. And whenever there were some attention seeking behaviors like shouting in the middle of the street if the demands are not met, or so because of that, family has to change multiple homes because the neighbors used to complain all the time. And there were also frequent risk taking behaviors like rash driving and bike stunts without using any safety measures. And also there was a conflict with law for Ali stealing or from a supermarket, and they have complained against him, and he spent one day in the jail also for stealing. And later, based on the request of the family, and case was closed, and currently right now is not having any legal issues. So substance use history, according to the patient, he started using cannabis at the age of 19 years, introduced by his friends. He says he started going to his 11th grade. He has failed multiple times in his 10th grade. When he went to the 11th grade, so his friends started introduced to him. Initially, he was getting for free from his friends. Later, when they started asking for money, he used to demand money from his parents, like 1,000 to 2,000 Indian rupees. It amounts to 12 to 24 US dollar per day from home. And patient reports that since then uses 4 to 5 joints per day. This is slightly unclear because he was refusing to disclose in the beginning. And also family has noticed throughout the day used to sit inside the home and use cannabis, but he denied using this. But family has definitely noted and have taken from his pocket that multiple pockets of cannabis. And so again, family is not clear about the using pattern, and he was guarded about the substance use. He was a bit reluctant to explain all this. So, and coming to other clarification, so we have clarified regarding any mood disorder in him. So we couldn't identify any history suggestive of mood disorder. There was no history suggestive of psychosis. And also there was no history suggestive of any anxiety or panic attack or OCD. And apart from cannabis and nicotine, there were no other substance use. So on the day of admission, he was brought to the outpatient department without his prior information. So he was always denying to quit the substance or seek help for his substance use. So family told, like his mother told him, she has to go for consultation, and has taken him to the outpatient department. So when he got to know, when doctor started interviewing, he tried to escape, and significant physical aggression was there, like he tried to hit or break the glasses. So that point of time, when there is a verbal de-escalation was tried, when it was failed, he required sedation with injection lorazepam in view of severe aggression. And then also he continued to have verbally abusive behavior, which lasted for 15 minutes. And mother says this is a normal behavior for him. Whenever his demands are not met, he used to scream like similar way. So family history, his father was a grocery shop owner, and he died at the age of 56 years because of the myocardial infarction. And he had nicotine dependence. And mother was a homemaker, and now she is the sole earner in the family who is taking care of the grocery shop. And he has two elder sisters. One elder sister is diagnosed to have depression, and she's on treatment. And another sister, she's 23 years and studying. So coming to the family history, his family is a nuclear family. After his father's death, which was a recent event, and he started, my mother started heading the family, and currently is living with his mother and two sisters. Elder sister again has separated from husband and has depressive episode on treatment. Currently, mother is a sole earning member of the family, and earning is very minimal. It is around $12 to $20 per day she is earning. So treatment history. So family has taken him to the hospital for the similar complaints once. He was treated with tablet oxcarbazepine up to 600 milligram. The reason for starting oxcarbazepine is not clear, because we couldn't get in the treatment history, and there was no history suggestive of bipolarity or any seizures that time. It was ruled out by doing EEG, and it was normal. And IQ assessment were done earlier twice, and latest one was around 6 months back, which showed 60 through Binet-Kamath test, which is most commonly used in India, which suggests of mild intellectual disability. So overall history in his time, I can show it as a timeline where he was born through full-term cesarean section, didn't cry immediately after birth, and he was in neonatal intensive care unit for a week, and also he had undescended testes. For that, surgery was done at the age of 6 years. And early developmental history, there was a delayed global milestone delay was there, where speech, gross motor, and social milestones were delayed. So he started schooling at the age of 5 years, and drooling of saliva was there, poor interaction with the children of same years. Surgery was done. And around 4 to 10 years, family noticed significant inattention, hyperactivity, restlessness, poor academic performance, frequent complaints from the teachers and neighbors, and toilet training was not there till he went to the 7th grade. So again, in the early adolescence, where he had a lot of frequent demanding behaviors at home, aggression if demands were not met, gang activities, impulsivity, and restlessness. And at the high school, around 17 years, first use of alcohol, cannabis, and smoking cigarettes. And family and patient clearly reports that alcohol use is not a problem. He has tried once or twice. Only cannabis is the major concern right now. Okay. So again, after failing his 10th grade exam, he continued cannabis use, smoking cigarettes, occasional alcohol, gang activities, demanding money for cannabis use, stealing money was there. And IQ assessment, as I already mentioned, it was around 60 and evaluated for seizures at a private hospital with normal EEG, and carbamazepine was started. After this father's death, there was an emotional callousness, increased demanding money, against stealing and smoking cannabis continued. So in general physical examination, he was oriented to time, place, and person. Once he came out of the sedation, we examined for any other physical dermatological examination didn't reveal any needle or puncture marks suggestive of any IV drug abuse. His pulse and BP was normal, and we observed some changes like low set ears. Minor physical anomalies were there, like multiple bushy eyebrows or low set ears. These were and also there was high arch palate was also there. And also small healed injury marks over the body due to frequent falls were there. And overall systemic examination, cardiovascular, gastrointestinal system, respiratory was almost within the normal limits, and gait was normal, and neurological function was also normal. BMI was around 22.6 kg per meter square. And mental status examination, once he came out of the sedation, he was conscious, oriented to time, place, and person. He was cooperative but guarded about the substance use, and his speech was normal in tone, tempo, volume, and relevant. No thought abnormality was found, and mood appeared euthymic with normal range in reactivity. No perceptual abnormality was noted. And again, there was poor judgment and absent insight, and also there was pre-contemplation stage of motivation for the cannabis use. So we diagnosed him with cannabis dependence syndrome, nicotine dependence syndrome with mild intellectual disability based on the ICD-10 criteria. Because this during that time ICD-10 was predominantly used. Now we started using ICD-11, and also clinically and clinical examination and objective examination revealed like ADHD, and also in the past he had received diagnosis of conduct disorder. So investigation, biochemical and hematological investigations were normal findings. Urine toxicology suggestive of the recent cannabis use, and ECG and SpO2 saturation had normal findings. Vendaruta scale for the ADHD evaluation, which was 60, suggestive of ADHD, and IQ testing also suggestive of mild intellectual disability. So for this person, we based on the discussion with the team, so we found out that the non-pharmacological management was a major mode for treatment, because there is a lot of things which need to be educated to the family mainly regarding the substance use. Especially we psychoeducated the family regarding the substance use and what needs to be done, how to support him. And this is considered as a stigma, especially in India. Any mental health illness is considered as stigma, and also substance use also, it's considered as a very stigmatic condition. So that's how we encouraged them. We appreciated them for seeking the help, and also we educated. It's not only related to the education. Family was mainly concerned regarding the educational aspects. So that we tried to educate. And also he was not so, as the person was not so keen on education, so we tried to tell him like, so continue the inpatient care, and then we can discuss over a period of time. So that he agreed to stay at the hospital. And also family therapy was considered mainly because of the maladaptive communication patterns in the family, especially as the elder sister, she separated from the husband, and mother was the sole source of income. There were frequent fights in the family, especially related to the substance use. So that we educated the family regarding how to approach him, how to manage his anger control techniques, how to maintain the boundaries. All those things we discussed using the family therapy. Again, one of the most difficult task was to for the motivational enhancement therapy. So yeah, even though he was in pre-contemplation stage of motivation, this was fluctuating over a period of time, and we were happy. We included as a treating team involved psychiatric social worker, clinical psychologists, and psychiatrists, and they did collaboratively, and finally he reached a stage where like there was a contemplation and preparation motivation was there. And also one of the major aspect regarding the vocational rehabilitation, which we identify certain strengths in him, that you once he likes the task, even though most of the task he takes time to learn. When we were sending, there is a place in the institute where we do certain training, especially for the rehabilitation of the patients who are capable. So where he learned to make the paper bags, and also because he passed the 10th grade, and later point of time he was able to apply for some local shopkeeper jobs, where he was trained to how to manage and keep the things in order. That was trained for him, and also he was able to learn over a period of time and used to clearly manage this task, and we identify it as a strength, and based on using the strength-based approach, we try to rehabilitate him. And when he was discharged, pharmacotherapy mainly we initiated on methylphenidate to manage the ADHD, and he was on up to 30 milligram of tablet methylphenidate, and baclofen, 50 milligram of baclofen, and nicotine patch we use for the craving management. So this was the current pharmacotherapy. And one of the success story about him in the recent follow-up had seen him 2 weeks back. So he's continuing in his job for the last 2 months without any complaints. He's continuing to take medication and regularly following with the treating team. So that itself, we feel it as a great achievement, and also it provides us a satisfaction, because when he came, he was having conflicts with law, and also a lot of issues, and family is also, mother is able to manage her grocery shop with 2 of her daughters, and son is able to do work independently. That itself, family is now coming to a stable phase, which they have not seen after his father's death. So this is my case. So open for any questions. Thank you so much.
Thank you so much, Sachin, for your presentation. I guess now we have some time still for some Q&A.
Yes, please.
So if you want to write in the chat your questions, you're very welcome. And equally, if you want to unmute yourselves and ask the questions directly, I think we can also accommodate 1 or 2. But I hand over to Professor Alex Baldacchino. Perhaps you want to start by sharing your views about this case.
Yes, Sachin, this is one of those cases where you start saying, where am I going to start with? There's a long list: conduct disorder, ADHD, intellectual disorder, cannabis, nicotine, and of course, you were lucky because you might have had a case with polydrug dependency, personality difficulties, etc., etc. So in a way, I'm really impressed with the fact that you did a very extensive history taking. And I think that's so fundamental. It might look like superfluous, trying to see if the person was born by cesarean section or not, but it is important. Every information is important. But what I was very impressed is that you, at the end, managed to formulate the case in a way that clarifies the direction of travel. Sachin, my thoughts about this is that, yes, I think would be mainstream general psychiatry that you get a lot of this type of presentation, especially adult ADHD or other neurodevelopmental disorders that were not diagnosed before the age of, 18 or so. And you find yourself as a clinician treating or managing things symptomatically. So somehow, you prescribe methylphenidate, and you see what happens. If not, then, you would prescribe something else and see what happens. I have some notes here. They're not criticism at all, absolutely not. Actually, since you have done this case in such great detail, I was wondering if perhaps you would go back to the patient and explore a couple of items. And they're very much based around the cognitive elements. You mentioned emotional callousness, which I'm assuming is the same as emotional intelligence,
Yes.
or lack of. You mentioned intellectual capabilities or impairments. But what I didn't see is that in-depth cognitive assessment around compulsivity, impulsivity, memory, because I think in due time, as this person grows older, there's going to be an issue around communication. So things like motivational enhancement therapy is based on an assumption that the cognitive state is normal enough or able enough to think in abstract terms. But I suspect in this case, there would be a very strong concrete thinking frame. So it would help to go back and explore further beyond the mental state examination, which you've done, in great detail, beyond the intellectual, but into the realms of compulsivity, because then you start exploring neuroscience-based prevention and treatment-based modalities, which are, as Parnian and others can tell us more about that, which are in the forefront of treating people with comorbid conditions.
Yes. Thank you. That was an excellent suggestion, and definitely we'll go back and look into it. And also regarding the motivational enhancement therapy, it was mainly regarding again, as you said, it was just concrete. So we used to tell certain things and used to do it like reward kind of thing. So if you do this, so you'll be able to you will get this item. So like that kind of motivation he got. That's excellent suggestion. Will take into consider as the next follow-up comes. So we will look into the cognitive aspect. And one of the limitation was the financial constraint from the family to undergo certain tests, especially regarding the imaging and all. So that was the one of the constraint we had. Apart from that, with the available resources, we'll definitely look into the cognitive elements in detail.
Thank you.
I think there's like a question in the chat. Perhaps you can comment on, Sachin. I think Roshan was asking for some more details in terms of treatment of cannabis dependence. So could you maybe expand on this?
Okay, thank you, Roshan, for the questions. And the question says, was comorbid ADHD ruled out in this case? Yes, we ruled out. And regarding treatment, any pharmacological treatment tried for cannabis dependence? Yes, I had mentioned we have seen in our clinic where some people with we do use N-acetylcysteine and baclofen as the treatment modalities, and we tried baclofen in him, and we felt some early response was there. So we have tried up to 50 milligram of baclofen, and for methylphenidate we have used in a dose around 30 milligram is on right now.
Okay, thank you very much. I guess if there aren't any further comments or questions, then I can hand over to Preeti. Thank you so much, both of you, for excellent presentations. And I hand over to Preeti.
Thank you, Dr. Mariana. So I would like to thank the chairpersons, Professor Alexander Baldacchino and Professor Afzal Javed, who are the presidents of ISAM and WPA respectively. So they had been very supportive, and they had always given a go ahead in all the initiatives, especially done by the early career professionals. So I would like to thank them especially for giving a go ahead for this joint webinar. I would like to thank the speakers, Dr. Angeline and Dr. Sachin Nagendrapa, for bringing in such beautiful, wonderful, and difficult cases, which we do face in our clinical population, and for bringing in the complexities involved in patients who are suffering from addiction. And I would like to thank the moderators, Dr. Rosen and Dr. Mariana, who are the chairpersons of ISAM-NExT and WPA-ECP. So again, they have been a very beautiful leaders for our respective committees, and they had been guiding us, and they had been very supportive of all our initiatives. And I would also like to thank all the ISAM-NExT and WPA-ECP members who had been supportive of this endeavor, especially Dr. Hussain and Dr. Who is the co-chair of ISAM-NExT, and Dr. Narasimha, who is a licensing officer of training committee from ISAM-NExT. So I still remember the initial talks in which we discussed we will approach the WPA-ECP and we'll start ahead with this webinar. So it was predominantly their initiative under the guidance of Dr. Rosen. And I would also like to thank Dr. Parnian, our previous member secretary, for all the background efforts. And last but not the least, all the audience, all the delegates who have registered and who have participated in this webinar, and for the active discussion here, I would like to thank each and every one of you. Thank you, one and all.
Thank you very much.
Thank you all.
Thank you all, and looking forward to the next webinar and things happening between WPA and ISAM-NExT. And good to see you all.
Thank you, everyone, and see you
Keep
soon.
safe. Keep safe, everyone.
You too. Bye.
See you. Bye.
Bye.